Do I have something to? Hi, I'm Mike Karasik from Hartford Hospital. Do we have a clicker so I can change slides, or how does that work? This is slightly different than the talk I gave last year, because as I was thinking about it, I thought it was better suited to, I think, your interests probably, and my interests, my research interests, which I think are going to overlap a lot. But we can talk about any aspect of pancreatic cancer, Dr. Curtis and I, and so if there's something that I don't touch on that you want to talk about, we can do that. Last year was more of a general overview of pancreatic cancer. This year, I thought it might be better to talk about preventing pancreatic cancer, excuse me. We know that pancreatic cancer has very bad outcomes. I don't think I need to tell anybody in this room that. And treatment is what Dr. Curtis provides and oncologists provide, but unfortunately we don't do as good a job as we would like because we find tumors so late. So really prevention is the best thing that we can do if we were able to in some way accomplish that goal. Oop. Unfortunately, we can't get to slide 2. This is a pointer, but how do I advance the slides? All right, much better. It would have been hard to talk off of that introductory slide for the entire period of time. So just some basic pancreatic cancer statistics. Pancreatic cancer is the 3rd most common GI cancer, and it occurs in about 12 of every 100,000 people. The mortality is about the same. So most people who have pancreatic cancer, almost everybody, is going to die from pancreatic cancer. We'll do the best that we can to prevent that, and sometimes we're successful, but there are a number of stumbling blocks we have to overcome. Surgery is the only potential curative treatment. Only 15 to 25% of patients with pancreatic cancer are candidates for resection, however, usually because we find it too late. The other problem is that they have to be healthy enough to undergo surgery, and Dr. Curtis will talk more about that. Size is a key issue with pancreatic cancer. When the tumor is larger, let's say here greater than 3 centimeters, the 5-year survival is much less than even if it's 2 centimeters, but still, a 5-year survival of 17.2 months is not very good. When you find tumors that are 1 centimeter or less, then you start having much more significant increases in survival, although still, it's often not a curable problem, via operations. But there are a series of people living 4 years, and I had somebody who lived 7 years after a tumor that was removed that was 1 centimeter in size. That's significantly better than most pancreatic cancers that we find. This came from an interesting article in Nature magazine, one of the foremost scientific magazines. And what they found, the long and the short of it is, that it actually takes about 22 years for pancreatic cancer to develop to the point where we see it. 22 years. That is a very long time, actually was a shock to me. The problem is we only find these tumors in this stage over here at the end of 18 to 22 years when they already have metastatic capacity. That's the problem. We're finding these tumors too late. They don't have symptoms usually until they've grown too long. And that's why I want to focus on prevention. There are groups that have particularly high risk of pancreatic cancer. And I just gave this talk this morning to the medical grand rounds to Hartford Hospital, and you'd be surprised how many physicians are not aware of all of this. And so I think it's important that you be aware too and pass it on as well, because we can do a better job. And I'm not talking about Hartford Hospital, I'm talking about nationally. and internationally. The hottest topic these days is precancerous states, and that's only been a hot topic in GI medicine for just the past 3 years, 3 or 4 years. So the two groups that have high risk, the ones we can find before they become pancreatic cancer and cure or prevent, are those that come up through genetic syndromes and those that have precancerous states. Let's start by talking about genetic syndromes. These are very rare. Last year I was surprised to find that quite a few people in the audience were being screened because they had these things. So it may be that in this room it's not quite as rare. But in general, these are very unusual conditions. Putz-Jaeger syndrome, for example, a condition where polyps can grow throughout the GI tract, but there's increased incidence of breast cancers, other cancers, and pancreatic cancers in particular. The increased risk over the general population is up to 100-fold. That's significant. The lifetime risk is 11 to 36% by age 70. Hereditary pancreatitis is another one. People develop pancreatitis in their teens, sometimes a little earlier. And the risk is so high that if a complication of pancreatitis, inflammation of the pancreas occurs, we sometimes recommend just to take the pancreas out at that point in time, because 25 to 40% of those people will develop pancreatic cancer. And the risk is twice as high if it's passed on from the father than from the mother, for unclear reasons. And if any of these high-risk syndromes are present in somebody who smokes, the risks double again, and the cancer occurs up to 20 years earlier than it would have. Another rare condition, but certainly ones that we see, are familial atypical multiple mole melanoma syndrome, a syndrome where people get lots of moles, melanomas, and pancreatic cancer. And again, a significantly increased risk. What we often think about when we think about cancers are genetic syndromes involving just that cancer. And so people often tell me they have a family history of pancreatic cancer. But unless there's more than 2 first-degree relatives or a first-degree relative and a couple of close non-first-degree relatives, that's considered sporadic pancreatic cancer. The risk is not really appreciably different than the general population. But as they go up in number, 4.5-fold higher than the general population, 8 to 18, 32-fold higher if there is a first-degree, more than 3 first-degree relatives. Now, everybody comes with different mixing and matching of cousins, aunts, and uncles. But somewhere in there is the relative risk, and it's significantly higher. I will add that the only people who have an significantly increased risk of pancreatic cancer from one first-degree relative, and you know what I mean by first-degree, mother, father, brother, sister, is if the first-degree relative developed pancreatic cancer before age 40 to 45. That is marked risk, just the same as probably this.
Can I ask a quick one? Is that, when you say developed, and you said it takes 22 years?
Right, the process has been going on that long, but a formal tumor has not developed. There's nothing to see.
So it's the formal tumor that has to
That's right, that's right. The genetic mutations that are developing to make that tumor spread and grow into some type of a mass take that long. On average, there's about 60 genetic cancer-type mutations that occur in every pancreatic cancer. So they've got a long way to go, and there are different mutations in different cancers. Not everybody requires the same mutations to take place. You've probably heard breast cancer gets a lot of notoriety about hereditary breast and ovarian cancer syndrome. That's on the news more, the BRCA syndromes, BRCA2, BRCA1, more common in people of Ashkenazi Jewish heritage. And there, the 2s can have an increase up to 10-fold. And then another thing that we often talk about these days in medicine is the HNPCC syndrome, the Lynch syndrome, where people, again, it's a polyposis, lots of colon polyps, lots of colon cancers, but cancers of the stomach, cancers of part of the kidney, cancers involving the pancreas. And so when we find that, we're going to start screening these people. And we are screening these people, but most places in the country do not. You have to be at a center where they do that type of thing. Here's an example of the value of screening. This is from Johns Hopkins. And what they did is they looked at 72 patients with a strong family history of pancreatic cancer. That's 2 or more relatives, first-degree relatives. And 6 patients with Peutz-Jeghers, and they compared it to 149 people who had no risk. The long and the short is, by screening, just one endoscopic ultrasound screening, they found 10% had a precancerous or cancerous lesion. So many of these people were cured. This is a precancerous lesion. These came out in surgery. That person is cured. This person, who had no symptoms, these are just screenings, had invasive cancer. I don't think this person was likely to be cured. And this is a very early one that had a good chance of being cured. That's just from one endoscopic ultrasound, which is the best test for screening. So it's very important that we do a better job as physicians and as the community in recognizing family histories. And when I talk to my own patients in the office, they often just think about the pancreatic cancer. But you have to think about other relatives with colon cancer, breast cancer, stomach cancer, all cancers, because that will provide important information. It may not be familial pancreatic cancer, but it could be a familial syndrome with a high risk of pancreatic cancer. The cancer is the same. So who is screening recommended for? Well, really, if the relative risk is 10-fold or greater, absolutely. If it's 5 to 10-fold increased, I'm usually doing it. Okay, there are other risk factors for pancreatic cancer. They include chronic pancreatitis, inflammation of the pancreas. And when someone's had that for 10 years, you start seeing pancreatic cancer. 1.8% will have pancreatic cancer after 10 years of chronic pancreatitis, and 4% at 20 years. Diabetes mellitus is very interesting. I'm going to have a separate slide on that. Cigarettes, well, we all know cigarettes promote cancer, and the relative risk increase is 1.5 to 2.5. In the high-risk syndromes, it occurs 10 to 20 years earlier. If you stop smoking, after 2 years, the risk is reduced by 50%, and after 10 to 15 years of cessation, it's back to normal. Obesity also plays a role, but this is very high body mass indexes. The very heavy as compared to those that are very light have a 2-fold increased risk. And a study from the University of Michigan showed what a lot of people expected was that heavy alcohol, heavy chronic alcohol intake is probably a separate risk factor, independent of cigarettes, which often go hand in hand. So on diabetes, there's an increased risk of pancreatic cancer in patients who have type 2 diabetes. It's 7-fold increased. This is a study from England looking at 2.4 million patients. Patients who had type 2 diabetes had a 7-fold increased risk as compared to those who did not. If they had diabetes and chronic pancreatitis, it was 12-fold higher. And it was higher, particularly in people who had diabetes for at least 5 years. The other is the next one is very interesting. People who have a new presentation of diabetes, sometimes pancreatic cancer is the cause of the diabetes as opposed to the other way around. Most people with type 2 diabetes are overweight. They have a family history of diabetes. But there are some people who are not overweight, are not gaining weight, they're losing weight, and they don't have a family history. When they present with diabetes, we really should be checking them for pancreatic cancer. Okay, now some of the precancerous lesions. These are cysts that I'm going to talk about, pancreatic cysts. Cysts are found all over the body. I was just asked about it earlier. Cysts in the spleen, cysts in the liver. Not all cysts in the breast. Not all cysts have premalignant potential. And pancreatic cysts were only recently recognized to have pancreatic cancer potential in many of them. So we now are paying a lot of attention to pancreatic cysts. The scary thing is that cysts are very prevalent in the pancreas. If you do an MRI in the general population, hospitals do them all the time, gazillions of MRIs, 14% of those with abdominal MRI done for some unrelated reason, are going to have cysts in the pancreas. That's a lot. Now, not all those people are going to develop pancreatic cancer, certainly not. But there is at least one study showing that if you look at these cysts, using autopsy studies, up to 3.4% of them are going to have the beginnings of cancer in them already. And here's the most interesting thing, I think. 8 to 20% of pancreatic cancers pass through a cyst stage, which means just like when you get a colonoscopy for colon cancer prevention, and you find a polyp, which is not a cancer, it's a precancerous thing, and you can remove it, this is somewhat analogous. It's not so easy to remove a pancreatic cyst. I have to call Dr. Curtis. But there's a time period when you may actually be able to prevent the cancer in someone who is destined to have it otherwise. And once that cyst turns into a cancer, it's old-fashioned pancreatic cancer. It's not slow anymore. Not that all cysts pass through slowly, but many do, much more slowly than a solid tumor. There are lots of different kinds of pancreatic cysts, and as I said, this was a talk for physicians, so I'm going to skip over a bunch of things. But when you look at radiology reports, oftentimes they see these cysts, and they're not all that impressed. They think that they can tell. I think the radiologists do a phenomenal job, but they're much more confident in their ability to tell what a cyst is. Is it a benign type cyst or a cyst with malignant potential? Much more confident they probably should be. They report 85% of cysts being pseudocysts, not real cysts. They're fluid collections related to inflammation of the pancreas. But when you analyze these, up to 40% of these are actually tumors or tumorous cysts. They're not cancer yet. And the kind of cysts that we worry about as a precancerous state are those that involve the pancreatic duct, the main duct, the side duct, and the mucinous cystic neoplasms, which are almost always in women. This is what a pseudo, is anybody interested in this? I'm not sure. Everybody eating? Am I going to hurt anybody's dinner? We'll just scroll. So these are just pictures of some cysts. So this is what endoscopic ultrasound, the test that I do most when I'm evaluating the pancreas, looks like. It's an ultrasound, but it's done from the inside. So like an endoscopy, you swallow a telescope while you're sedated. We do ultrasound from the inside, and because we're so close to the pancreas, the image quality is better than CAT scans. And so here you can see a cyst. This is a benign cyst, one that actually does not have malignant potential. It has features that show that. This is the same kind of cyst, although you can't tell. This has features which could be premalignant or not. And so what we have to do, I'm just going to scroll through here, is we have to put a needle in these cysts. Take some fluid out. We have to analyze it. And an X-ray just won't do that. But by doing that, we can actually find the people who have a precancerous state. If we really want to make a difference and prevent pancreatic cancer, this is the best way. Find the high-risk groups, find the high-risk precancerous lesions, got to identify them, and then we can follow them, operate on those that need it, don't operate on those that don't, or just watch because they may never change. We don't want to operate unnecessarily. This is that main duct type I was talking about. I showed a picture of the main duct being involved, and here's a little tumor growing in the duct. This is very small. This tumor is probably 8 millimeters in size, but it already could be invasive and it already could be metastatic. Here's a big, looks like a polyp growing in the main duct. And another one. But these are all endoscopic ultrasound pictures. You really need a very sensitive test to be able to pick these out. This is a side branch cyst, completely innocuous looking. There's no growths inside, there's no wall thickening, but the lining, the true lining, can't be seen. You can only tell under a microscope. It's not, we wouldn't want to operate on somebody to take this out, but if you put a needle and you take some fluid out, we may be able to get some of the DNA out of it, some cells out of it that we can evaluate, and we'll be able to have a better chance of determining whether this is someone that should be followed or a lesion that should be removed so that cancer doesn't develop. IPMNs are the type of cysts I'm talking about now, the ductal abnormalities. And what you can see is that when the cancer develops, they start behaving just like the solid tumors. These are survival curves. They become invasive, they metastasize. These are the things we look for in the fluid. And I'm showing you this to you, having just shown this to a bunch of doctors who didn't know this either. Because this is still fairly cutting edge, and it's one of the things that we're studying with the support of Ron's Run for the Roses. We're evaluating these technologies and trying to come up with some composite scores to help identify who needs what. A bunch of criteria were set up in Japan, some of the world's experts on these cysts. As I said, they've really been a hot topic just for the past 4 or 5 years, really. But it met in Japan first in 2006 and most recently in 2012, and they came up with criteria for when you can't tell what the cyst is by looking at it with endoscopic ultrasound, CAT scan, MRI. What do you do with it? Well, the long and the short is, this is probably not even correct. This is their algorithm, but it takes for granted something which has since then been shown, and that is that the size of the cyst is really not all that important. Whether it's less than 1 centimeter. In Marcia Canto's study, that screening study, one of the pancreatic cancers was in an 8-millimeter cyst. Size is not important. Size is a big part of this algorithm, and I suspect when it meets again in 6 years, the group is going to change. For the first annual the Hartford Hospital Pancreatic Cancer Symposium that we had this year, our keynote speaker was Max Schmidt, who is part of this committee, and he actually was showing some very impressive slides. He disagrees with this algorithm completely. But the important things are the things that you see with endoscopic ultrasound. Is there a thickening of the wall, implying growth? Is the duct very large, because they get filled with mucus and they expand? Is there a growth within the cyst? Those are the things we look at. All of this slide is really pretty much showing the importance of size, and size is really not so important. What you really need to have is you need to be thinking about the problem, because the small cyst that the radiologist and your primary care doctor and me only 5 years ago is going to blow off should not necessarily be blown off. So there are a number of reasons to send someone to the operating room. We talked about a dilated duct. Here's a tumor marker. We talk about CA levels of 4 and 5 being dangerous if somebody had colon cancer or breast cancer. But this is not in the blood. This is in the cyst itself, so they can be much higher. And I had one patient with a CA level of 136,000. She did have cancer, but you don't need a CA that high. Over 192, and more often than not, it's a mucinous cyst. Those are the kind that can go on to cancer. You look for thick cyst walls, associated masses, growth inside. If the cyst is growing over time more than you'd expect, I mean, they can grow slowly. But if it picks up speed, and that's why they really have to be followed, that's another sign, even if you don't see any of those other markers. This is our first 132 patients. We're way beyond this right now, but it takes a long time to analyze all this. And what I did is I compared the endoscopic ultrasound findings with the cytology when the fluid is taken out and you look under the microscope, and the cytologist tells you whether they see tumor there or not. The CA level, DNA markers, we now look at DNA, and what we ultimately got. And of the first 132, these are 18 patients who either had cancer that was operated on or a precancer state that was cured by an operation, or they either couldn't get surgery because they weren't healthy enough, or some refused. But we know what the diagnosis is in these 18. And what we found is that the most important thing, you haven't seen this data yet, Dave, I haven't shown this to you, is that EUS, just the way it looked, even before you put a needle in it, was the most helpful. When we said it was an IPMN, in 4 cases, there were 4 IPMNs. 1 had invasive cancer. One had carcinoma in situ. That means it hasn't gone anywhere, but it is a cancer. But that's still curable, potentially. One had high-grade dysplasia. It's pre-carcinoma in situ. That's curable. And one had moderate dysplasia, which is one step before this. That's curable. We had someone with a side branch IPMN with a thick wall. This person refused surgery, but I think in the future, the outcome is not going to be good. And we had some that are indeterminate. We had 9. We weren't sure what kind of cyst it was, but we knew it had some worrisome features. And so they were either gigantic, never mind the size, well, these were very big, or they had a thick wall, a nodule inside, adjacent organ involvement. And of these 9, there were 4 cancers, a precancerous cyst, a precancerous cyst, a precancerous cyst, and 2 unusual types of tumors that also needed to be removed that can sometimes make cysts. So EUS was really, I mean, it predicted in 88% of people, many of which would not have been able to be predicted by CAT scans and MRIs, which is the usual way that cysts are found and followed. In truth, I only see a very small percentage of those patients who have cysts on those studies. I calculated about 3% per year of the ones that, of the anticipated number of cysts. But I'm sure your doctors don't know about it, and it's not, I'm not implying they're providing bad care. This is hot off the press stuff. And so it still is going to take a number of years for people to actually understand this and know what they can do about it. Cytology is also key, and you can only get that when you put a needle in it. It's not that sensitive, but when it's positive, when it's positive, it's positive. And it predicted, independent of morphology on endoscopic ultrasound, the need for surgery. Looking for a composite score is something we're very interested in because you may have a sign here that's not so good, a sign here that's not so good, but none of them be really, really bad in and of themselves. And the question is, does a composite score help you determine who needs surgery? Because the worst thing would be for us to follow somebody and not think they have cancer and then miss that. On the other hand, we don't want to send someone to the operating room for major surgery if they're not going to benefit from it, if they don't need it. So we're always somewhere in between there trying to do the best that we can comparing relative risks. So this is a study that I hope is going to take place in 2014. It involves, what are we up to now? 8 medical centers across the country, of which Hartford Hospital is one of them, with the support of Ron's Run for the Roses. And we're going to be looking at 500 patients with cystic neoplasms and looking at these group models to try and better figure out, even better than we're doing now, we could always do better, which patients would benefit from surgery to prevent the cancer. So when we want to beat pancreatic cancer, well, we want to identify the earliest lesions. The smallest lesions is the best. But there are no symptoms associated with them, so that's a tough thing. You have to be somewhat lucky to find them that small. You have to be looking for something else. The real key in my mind is going to be prevention. We have to really look into the family history. And I was telling physicians today, you can't just look at first-degree relatives. And when I ask my patients about their family history, they only tell me about their first-degree relatives. You have to get more information. And when there is a high-risk state, whether it be a precancerous lesion or a genetic syndrome, they need endoscopic ultrasound, at least annually and sometimes more. We want to reduce alterable risk factors, although I don't know how many of you smoke or tried stopping smoking. I could tell people all day long to stop smoking. It doesn't really work that easily. For the best results, you also want a highly experienced and coordinated team. People who see it all the time, work together all the time, like Dave and I and other physicians at Hartford Hospital. I think the future is really the most interesting thing. My hope is that we'll be able to come up with a prophylactic drug, just like there is for some colon cancer syndromes, that might decrease the risk of pancreatic cancer. And the other is once there is pancreatic cancer, the big push is to personalize the medicine, find genes that identify these particular tumors as the ones that are going to respond. Whereas right now we provide the same chemotherapy to almost everybody with a pancreatic tumor. The results are not going to be the same in everybody. There may be some individualization that needs to be done, I'm sure of it. So I'll stop there. But we can talk about pancreatic cancer in general after Dr. Curtis talks if you'd like. Or if you have.
What kind of prevention work we can do as an individual?
Well, depends what your risk is. For the general population, there really is nothing to do to prevent it. It's still so uncommon as compared to other tumors that it's just not worth the risk and the cost of doing these studies, even though I think endoscopic ultrasound is a very benign test. You still require sedation. It's still an invasive procedure. It's an endoscopy. I don't consider it invasive, but for the person who doesn't need it, it's just not worth it. It depends what the risk is. If the risk is high enough, then it absolutely is very important and worthwhile to do these things. But there's nothing that the general population can do to prevent pancreatic cancer. You want to not drink heavily. You want to not smoke. You want to avoid chronic pancreatitis, which is usually a result of chronic alcohol. But there's really nothing else at the moment.
What kind of symptom one has if she or he has cancer?
Until it presents most of its life, it's completely without symptoms. And that's why we find them so late. It's only by the time it gets big enough to cause pain, which is very, very late, or big enough to block the bile duct, which is still very late, depending on where it's located. There are no symptoms, none. That's one of the problems.